My name is Vicki Noble. I'm one of the ED attendings, and we're going to talk today a little bit about the FAST exam. And I think one of the things that I'm going to try to do in this session is to update your thinking about the FAST exam, because the original algorithm is pretty outdated, quite frankly. We don't really work like this anymore. So, the original algorithm was the consensus guidelines. The ATLS teaches this, and Scalia and a bunch of people got together. And so when you did this in 1999, you would do your FAST exam. If it was positive, they would go straight to the OR for a laparotomy. And we almost never do that anymore, right? We do a lot of non-operative management. We do angio. We do, wait and watch kind of thing. And how many of you guys have ever done a DPL? No. Zero, right? And not only that, that was the one where you infuse the bag of saline and then you put it on the floor, and no one does that anymore. So this is relatively useless, I think, way to think about the FAST exam. So I like to think about it. This is for the camera. So I don't go to proms anymore, and I don't have permed hair anymore. So the things that we did in the 90s, we don't have to keep doing in the 2020s because, yeah.
Which one are you?
Yeah. You want to know which one I am? Yeah, here. The baby blue. You guys guess which one? Which?
Baby blue rose.
Oh, I look good. Look at me. So we can evolve, and we can evolve our thinking, because I think it's a really powerful tool, but we don't use it correctly. And so I'm going to try to convince you in a new way to think about how to use it. So the way I think about it is sick, medium sick, and not sick. And so sick patients, the reason why I do the FAST exam is because I want to know where the bleeding is. Is it in the belly? Is it in the chest? Is it in the mediastinum? Because it changes the order of procedures that you do. It changes whether you do a procedure or not. It can change the order of operations, things like that. So I think that's where you add value, and we'll show you some cases in that. For medium sick people, it's actually not probably so useful for you guys, because they're all going to get CTs, right? They have a mechanism, they have something wrong with them, and so they're going to get CTs. But from an emergency department standpoint, I want to know when to do the CT. Do they have to bump my stroke? Do they have to bump my acute peritonitis? Do they have to bump my fell and is on Coumadin patient? And so the order of CTs and sort of triage that you can do with a FAST exam in a medium sick patient helps you organize your flow. And so if they're a medium sick person, but their FAST is negative, maybe my stroke can go first to CT and I can wait. Or if you're in a small hospital where you have to think about transfers and stuff like that, do I need to fly them? Can I do them by ground? All that kind of stuff. It kind of helps in your triage for the medium sick people, because we know they all get CT scans anyway. And then the not sick people is a little more controversial. Because sometimes I do FAST exams just to prove to the patient that I'm doing something, because I don't really want to do a CT because I don't think anything's wrong, but they need a test to reassure everybody that we are doctors and that we do tests. So sometimes it's a little bit like that. Or sometimes it's, maybe they're pregnant, or there's a reason I don't want to expose them to ionizing radiation, and so I do the FAST exam in the not sick person, and then we'll watch them or monitor them. But this is a little more controversial, because you're not supposed to use the FAST exam to rule out injuries, is sort of the teaching always. But I think we have such better machines now, and we can see so much more with our new technology, that I think this is evolving too, and so I just want to put it out there as like a potential. Now, I will tell you that, and this is for the camera because I'm sure other people will see this, that this is not the teaching here. If you're using FAST exam, you're using it to rule in disease, not to rule out disease. But I think this is going to change, and especially in pediatrics or pregnant patients or people you don't want to expose to ionizing radiation, there is a role probably in some triage there. Okay, so first of all, the sick patient. This was sort of the reason that FAST came about. And this is a study that was from 1992. A bunch of trauma surgeons in Denver stole the ultrasound machine at night from the radiology suite and started looking at their penetrating trauma patients who had injuries to the chest. And what they found was, if they did their own ultrasound, not only did those patients get to the OR faster because they could make diagnoses that needed OR treatment, but they had a survival difference. And this is pretty amazing, right? This is like rogue science that they figured out that if they could look and if they could make those diagnoses at the bedside, they had a survival difference. And that's pretty cool. But this is, this is not early science. This is 1992. So this is kind of what started the whole point of care diagnostic diagnostic imaging effort, and how to train people and how to get people to do this correctly. And I came from Boston about 2 years ago now to Cleveland, and this was a case right before I left. Whoops. And so this is where you really make a difference, right? So this is, if you have a hypotensive person, the first place you're going to look is the most critical area, which is the mediastinum. And if you have somebody with a clot in the mediastinum, they still have cardiac activity. You can see that they're not dead yet, but they're not doing well. And so these people need emergent thoracotomy. Whether it's in the ED or upstairs, it's always better if it's upstairs. Sometimes you don't have a choice. But if they come in and they have vital signs and then they lose them, this is where you can save lives. And so this was one of our cases. This guy came in at midnight. He had his thoracotomy 12 minutes later, and he went to the OR 20 minutes later, and he ended up surviving. So that doesn't happen a lot. And if they come in with no vital signs and a pericardial clot, there's good evidence from LA County and other places that those people are dead. So, but if they come in with vital signs, this is where you have a chance. And so if you have your surgical team and you guys are there and you can see this and you know where the injury is, that's where it really makes a difference. So again, this is sort of the sick patient. You want to decide if it's mediastinal or if it's laparotomy or if it's thoracotomy. Or chest tubes. So here you're looking, you see that there's mediastinal fluid or pericardial fluid, and so these are people who need intervention sooner rather than later. So these are the thoracotomy people. Here you can see that this is somebody who has a positive FAST but a negative cardiac ultrasound. And so in these patients, you are going to make triage to a laparotomy, not to like chest tubes and thoracotomy. And we'll talk a little bit how you identify all that different fluid in a minute. One thing I will say, and we'll do this in the hands-on, but this, do you guys know what view that is for the heart? So that's the parasternal long view, and ATLS teaches you guys almost always to do the subxiphoid view. The problem with the subxiphoid view is if you've ever been in a car accident or you've been stabbed in this area, not that you have, but if you had, it hurts, right? Because you got to push pretty hard, and there's a lot of distance in some people between this area and where the heart is. And if you have a hemothorax on the left side of the chest, when you're looking from the subxiphoid, you're going to hit fluid and then hit the heart, and you can make a mistake. You can think that fluid is in the mediastinum and not in the pleural cavity. If you do the parasternal long, you won't make that mistake because pericardial fluid goes over anterior to the descending thoracic aorta, while pleural fluid tapers to the descending thoracic aorta. So I will teach you this in the hands-on, but I really like this view. One, it's easier to get, right? You don't have to push. It's like centimeters below the anterior chest. Two, it helps you distinguish pleural versus pericardial fluid, and you get a really nice view of the function as well. So we'll show you that when we do the hands-on. But anyway, in this patient, you have negative mediastinal fluid, and then you see the fluid in the abdomen, and the teaching was that this patient would go to the OR. If they're unstable, that's probably still the case, but almost all patients get some resuscitation, and if they're sort of metastable, we still obviously do CT scans in these patients, but you know at least where the bleeding is and that this patient has something you need to address. And then finally, the third cavity where you can bleed, where you would need to do something, is going to be the pleural cavity. And so the reason why I like sort of the extended FAST is because when you're trying to decide what to do first, if you have a negative pericardial sac, you have a negative belly cavity, but over here you can see here's the liver, here's the diaphragm, and you can see the spine, and you can see that the spine extends above the diaphragm. We call that the spine sign. When you see the thoracic spine, what that means is there's something in the chest cavity that's transmitting the sound to the thoracic spine, and so that's fluid almost always when it's black like that. Whether it's a hemothorax or pleural effusion, it depends on the situation. But this is really helpful because it's very helpful in identifying where the bleeding is. And so if you have two negative other cavities, then you can focus on doing your tube thoracostomy first instead of doing unnecessary other testing or going to CT first or something like that. If you don't have fluid in the chest, the diaphragm and the spine come to a point because the air in the chest is blocking the sound from reaching the thoracic spine. So you have the diaphragm and the abdominal spine meet at a point, and you'll see this in our models because I'm pretty sure they don't have pleural effusions. So you can have that, and then you know that the chest is full of air. So again, really helpful for identifying where the cavity is. And for those of you guys who just came in, I was just telling them that I think we have to evolve in the way we think about the fast. The old algorithm of positive OR, negative DPL is ancient kind of teaching, and I think there's a much better way to use fast exam, which is more of a triage tool. So in the sick patient, where is the bleeding? Is it in the pericardium, the mediastinal area? Is it in the belly, or is it in the chest? And then in the medium sick patient, it's to help triage who goes to CT first, basically, because they all get CT. Okay, and then finally, how many of you guys have heard about lung sliding? Yeah, okay, perfect. So obviously, you know, you're only ruling in or ruling out the presence of lung sliding underneath the footprint of the probe, and we're not doing a whole extensive mapping of the pleural space in a trauma patient. But if you have a supine trauma patient who's hypotensive, and you kind of scan in the midclavicular line anteriorly and you see lung sliding both places, they're not hypotensive because of a tension pneumothorax. And so it really is helpful to prioritize how you do your procedures. Now, they may have a small pneumothorax that needs attention later, but it doesn't need attention in those first couple minutes. That's when you look at the heart, that's when you look at the belly, that's when you look for pleural or hemothorax. So up here you can see when the visceral pleura has dropped away from the parietal pleura, it's still moving. Obviously the person's still trying to breathe. You can see they're tugging that chest wall, but you don't get the slip sliding motion of the visceral and parietal pleura because they're not touching. This is what's called the lung point. And so this is where the visceral pleura is reattaching to the parietal pleura, so you have half sliding and half not sliding. And the reason why this is so useful is, again, not so much in the acute evaluation of the trauma patient, but we don't put chest tubes in everybody anymore. And so if you find the lung point, put an X there. If it's getting bigger, it's moving laterally. If it's getting smaller, it's moving medially. And so it's a really nice way to monitor the size of a pneumothorax, you know, certainly in the OR, or if you're going to not put in a chest tube, instead of like every time the patient coughs, they get a portable chest x-ray. And then finally down here is regular sliding. So you can see this slip sliding motion because the visceral and parietal pleura are touching each other and moving back and forth. Does that sound familiar to people? Kind of? Okay. So, and actually, the other thing that's important is that this is relevant beyond trauma, obviously. Like every time you do a thoracentesis, this is a quick way to look with the ultrasound to make sure that there's sliding under where you just put your needle. Or every time you do a subclavian or a central line, you can look for that sliding to make sure there's no pneumothorax. You know, get a chest x-ray too, but it's certainly very helpful for your peace of mind. You can move on to other stuff in your brain. Okay, so making decisions, so cardiac, obviously if you see mediastinal fluid, you're thinking more thoracotomy. Abdomen, you're thinking laparotomy or angio, and then chest tube for the pleural fluid. And I think it just helps you in that sick patient identify priorities of what to do first. Okay, the medium sick patient, like I said, almost all of these patients have some mechanism or some vital sign abnormality. They're almost all going to get CT, of course, but the question is when. And so this is what, you know, emergency rooms look like. There's patients everywhere. And again, this is more our problem than your problem necessarily as the trauma team. But, you know, am I going to bump a stroke patient or somebody with, I'm worried about a head bleed for a patient with a negative fast? Maybe they can wait. I can do the other patient first. So it's kind of the, yes, they're going to get a CT, but when? And so I hear a lot of times, like, don't do the fast. You know, it's not necessary because we're going to go to CT. And that's true in the sense that that's where you're going to identify the injuries. But it's very, very helpful for triage, and so we use it a lot in that sense. It's also really helpful, the one place that this might be useful for you guys is also in post-op patients. So again, all fasts don't have to be traumas, right? So if you have a post-op patient comes to the ICU, look with the ultrasound, there'll be some fluid, of course, post-op, but then when they change, when they have a hemodynamic difference pre and post evaluation, you can decide is the fluid getting bigger? Is there more fluid? You can help triage things that way too. And then, like I said, the not sick patient is a little bit more controversial. I definitely use it in people sort of as a reassurance tool. If I don't think they need imaging, that's like a little fender bender, they want to test, doesn't seem to make sense to do CTs on all these patients. And as you guys probably know, we do CT more people in the United States than anywhere else in the world, and probably not for always good reasons. So I do think there's a growing body of literature for decision rules, how to use ultrasound in sort of triaging who needs a CT. And even when we do CT these patients, we find non-surgical lesions, and then you have a whole conundrum of what to do with these non-surgical lesions. So I just put it out there. I know in our system and with our trauma attendings that most likely these patients all get CT'd, I get it. But just to put it out there to think about, because there probably is a group of patients that we could avoid this in if we needed to. Pediatrics is also a little bit different because pediatrics, not all traumatic injuries bleed in pediatrics because they're a little more pliable. So a negative FAST doesn't have the same sensitivity in pediatrics that it does in adult. But a positive FAST means the same thing. So it's always worth doing because if you have a sick patient and you're worried about bleeding, then a positive is a positive. There are some nice algorithms that have been published looking at liver function tests or urinalysis in combination with FAST to avoid CT scans so you don't radiate little kids. But again, it kind of depends on your attending. So we'll show you the same stuff. Okay, so teaching points, it's not the same for all patients, so think about them differently. Sick patients, medium sick patients, not sick patients. The sensitivity and specificity are different in those different groups, and so use your test characteristics smartly. And then there's no reason not to do it. Information hurts you when you don't know it, right? So that medium sick patient is actually the one I do it in the most because then I know whether to worry about them or not worry about them and help triage. Okay, so let's do some cases. All right, so first of all, where do you think we are? Right upper quadrant, right? So you can tell it's the liver because you see the ducts and the veins. Would you think this is positive or negative? So what's this right here? Renal cyst, perfect. Don't get fooled by the renal cyst. But is it positive or negative?
I mean, there is something.
Yeah. Up here, right? So be careful. The most dependent part of the abdomen is the inferior pole on the right side. Is the inferior pole of the kidney and the tip of the liver there. So we always teach to, especially ATS teaches to look at Morrison's pouch, but that's not the most sensitive part. The most sensitive part is out here over these edges, because if you're lying supine, that's your most dependent part of the abdomen. So yes, of course, look at Morrison's pouch, but make sure you fan and make sure you fan through those tips because otherwise you'll miss that. Now again, this patient is not hemodynamically unstable because of that amount of blood, but this person can't go home, right? They need imaging. They need to figure out if there's active extrav, things like that. So, and then the other thing is just don't get fooled by cysts. Free fluid does not fall into circles, right? So that just doesn't make sense. But I've seen people, in the heat of the moment, they see black fluid and they call it positive. Okay, what about this one? So like I said, I came from Boston, and everyone in Boston who got in a car accident had a bladder that looked like this because they all came straight from the pub. Do you guys think this is positive or negative? First of all, they need a Foley or they need to pee, right? Their bladder's huge. So this is positive. This is all free fluid outside the bladder wall down here. So these are tricky. And the other thing that happens is when the bladder is full like that, if you don't set your depth as a little deeper than normal, you'll miss that, right? Because as you're fanning through, you'll just see this big fluid-filled bladder, and you'll miss these cul-de-sac free fluid down here. And I actually think the pelvic view is the hardest view in the FAST because there's a lot of stuff that can be hanging out down there and you can get confused with bowel loops or other things. But the machines almost all default to 14 centimeters or 12 centimeters when you turn them on, and you probably need more in most Ohio body types than 14 centimeters. So that's positive. All right, what about this one? So this is a trick because that's the gallbladder. So don't forget, and this is why fanning is so important. They aren't really fanning through that structure, and if you fan through that structure, you would be able to tell that it's a circle, and certainly you could turn it transverse. But the gallbladder oftentimes is right in that space. You know, it's a very mobile organ, as you guys know. This is your IVC back here. So I've seen people make mistakes with that too. The IVC goes kind of right anterior to Morrison's pouch. So again, we'll show you in the hands-on. That's why fanning is so important. What I see a lot of times in Boston, this is all the time, is people would put the probe right here and then pull it away, and they'd say it was negative. And that's useless, right? The whole point is to fan through the space to make sure that you get a sense of where the blood would collect. Okay, so this one is obviously positive, but is the fluid in the chest or the belly? It's both, right, perfect. Most of it's in the chest though, right? So here's your spleen, this is the edge of the diaphragm there, and this is all fluid in the chest because it's above the diaphragm. There's a tiny little fluid below the diaphragm there, and the other thing that's interesting is ultrasound is awesome for looking at the diaphragm. So diaphragms move when you breathe until they're ruptured, and then they don't move when you breathe. And so this is a little concerning for a diaphragm rupture, and you'll see when we do the models that you can look at the function of the diaphragm really nicely. And again, in trauma, you're going to do other tests if you're suspicious for a diaphragm rupture, but think about your thoracic surgery cases, like pre and post. You look at the diaphragm to see if it's moving pre, you look at the diaphragm to see if it's moving post, or people who you do interscaling blocks on, you almost always get the phrenic nerve, so you want to make sure that they don't have an ipsilateral diaphragm paralysis before you block the diaphragm on the other side. So there's a lot of cool things you can do with ultrasound that are outside the trauma sphere, but are the same concept, right? Looking at that diaphragm function. Okay, what about this one? It seems negative, right? This is your spleen, and it's very homogeneous. But you see how there's like a space up there, and you can see the fascial plane, that bright white line. So don't forget that clotted blood is going to look very gray and almost isoechoic sometimes to the splenic texture. And so you might worry a little bit that this is a whole bunch of blood above the diaphragm that's clotted. And so on the left side, remember on the right side I told you that the blood collects around the inferior pole of the kidney or the caudal tip of the liver. On the left side, the first place it goes from a splenic bleed is above in the subdiaphragmatic space. So yes, look at the splenic renal recess, but if you're worried about a splenic injury, it takes a lot of blood to fill up the subdiaphragmatic space, spill over the colic ligament, and then go into the splenorenal recess. So always try to, and we'll show you this in the hands-on, always try to see the subdiaphragmatic space when you're looking on the left. This is a little easier, right? This is trauma because it was a splenic injury with a colonoscopy. But you can see this whole huge subdiaphragmatic bleeding there. It's actually pushing the spleen down. There's even a tiny little bit. You can see the thoracic spine here above the diaphragm, but obviously the big problem is the spleen. Do you guys see that? Okay. And this is another one. Remember, the spleen should be very homogeneous. It has almost, uniform texture. And here, you see how there's like almost two types of textures? So this is a subcapsular injury, but when you see that heterogeneity in the spleen, it's either cancer or an injury. So you got to worry when you see that. And here you might even see like a tiny bit of fluid at the tip, but it looks really swollen. It looks very mixed density, and so that would be concerning for a splenic injury. The other thing I'm just going to tell you now before we go do the hands-on is the other group of patients that you have to be careful with are women, because we have a uterus. And if your bladder is empty, most women, the uterus anteverts over the bladder. And so what happens if you just look transverse is you'll see the uterus first, and then you'll see fluid behind the uterus, which is the bladder because of the anteverted uterus. But you may make a mistake because you think it's free fluid behind the uterus. So always, always look in the long axis, because then you won't make that mistake. It's much easier to tell the bladder is anterior, and you'll see the anteverted uterus. As the bladder starts to fill, it pushes the uterus back. And so then in a full bladder, the bladder will be in front of the uterus when you look transverse, but just look in the long axis. It just makes it easier so you don't make that mistake. Any questions? I had handouts for people with teaching sites, and the best one is the top one. It reviews a lot of the stuff that we talked about. And then we're going to do some hands-on next door. Yeah, here, I can pass that back in. I think one more back there.
How often does this using the ultrasound, outside of trauma, whatever, really like save you from getting a CT scan?
A lot. Outside of trauma, I use it more for undifferentiated hypotension. So, for example, if you have somebody who's hypotensive in the ED, you don't know anything about them, you look at the heart, you look at the belly, you look at the IVC, you get a sense of whether it's cardiogenic shock, is it septic shock, is it hypovolemic shock. So that's really helpful. And it can target what you need to do. Like if it looks like septic shock on your ultrasound assessment, then you do cultures and look for pneumonia instead of doing other stuff maybe. Or if it looks like cardiogenic shock, then you would do an EKG and look for BNP and look for that type of stuff. So I think it really helps. I would say in medium sick trauma patients, you're always going to get a CT, right? So that is not so useful, but like I said, the reason I do it is more to help prioritize and strategize how to use the CT scanner. And the sick people, it depends on your trauma attending, really. And here I've had mixed experiences. Some of the attendings always want a CT, and I get it. It helps, triage for the OR as well. But we certainly have had patients, we just had one not too long ago who had a big gunshot wound right here, big hemothorax, got a chest tube in the bag, got resuscitated, the mediastinum was negative, the belly was negative. And you end up getting a CT anyway at some point, maybe, because you want to see if things are re-expanded. But it certainly helps calm everyone down, because then we knew what we were dealing with. We had identified the cavity for the bleeding. Everybody kind of felt comfortable, was on the same page, waiting for CT until we did the chest tube. So those type of things, I think it can be helpful. I think the not sick patients are probably not the ones you guys see. That's the ones we just see in the ED by ourselves. And then it's more just comfort level, I think. I find it really helpful for patient education. Like, here, look, here's your kidney, here's your heart, look at your lung sliding. They don't know what it all means necessarily, but it reassures them. And pregnant patients too. We definitely can avoid CT scans in pregnant patients by looking, because they're all going to get monitored for 4 hours. So yeah, it depends. But
yeah, that's what I was going to, because a lot of that you were talking about, a lot of our trauma attendings, when we're dealing with thoracoabdominal things, they're adamant about chest X-ray.
Yeah.
And then I know they don't always mention fast. It's like if there's nothing in the chest and they're hypotensive and they have thoracoabdominal, then it's OR. Yeah. Not necessarily, but I mean that's what it is.
But here almost always the technicians are right in the room, and you can look at it on the machine. But there are places that you work where that isn't the case, and so then you have the power to do it yourself if you know how to read and interpret ultrasound. Certainly I've worked places where you have to call them, and then they come over, and then they go back and they develop it, and 20 minutes can go by in that time. And so if you know yourself ahead of time, it can just be reassuring or not reassuring. Yeah, good question. Any other questions? Okay.